also, those who survive till 65 years of age, and you can see that in the general population, or the world, or the population in Australia, based on world calculations, is about 9% of our of general population die before 65, whereas 30% of the Indigenous population die by 65. Another big issue. So we've got this map, this graph, which shows the disparity in life expectancy. A few years ago it was about 17 years. It's down to roughly 11 years, and I'll explain that in a second. But it's basically saying that as Aboriginal and Torres Strait Islander people, we are dying younger. Why is that the case? We all live in the same country. We all should be enjoying the same, delivery of services and the same, wealth as the rest of the population. But that's not the case. So there is this disparity, and as I said, it's currently calculated around about 11 years, but in the past it was 17 years. So this is a Lancet report, and it looked at some global indicators and how Australia fares compared to other countries and other major Indigenous populations. And you can see that it's only the Inuit who have a disparity gap equivalent to or close to what we've got in Australia. But for other developed countries, the gap is much smaller between the Indigenous populations and the general population. So that is also, one of the drivers. And then you start to look at why we're dying, and the major causes, and cancers and cardiovascular, etc. And a lot of those are preventable. And so we've got to look at that as a real issue. I use this slide, and this is a slide of my family, and it's taken a few years ago. That's me as a baby, about 50 years ago, maybe a little bit longer, but ago. But it's at a time up here when Aboriginal and Torres Strait Islander people still have a very close relationship to land, to culture, to language, and and that's one of the big contributors to good health. And so it's when people get dispossessed, and part of that dispossession is from colonisation and other marginalisation that happens, we see different outcomes. Now, my grandmother's the third from the left, my mother's mother, and they're Kongarakan there. But in this photo, there's only 3 of us surviving, my sister and one of my aunties. And so it was at a time when people did have a good age, very healthy, living off the land. But now we're seeing a lot of difference. In this photo, there's also one of my cousins who was the first known person in our family and to take her own life, and that was in the mid-60s, and it was late 60s actually. And so suicide is a fairly recent phenomena for Aboriginal and Torres Strait Islander people, but boy, we've really championed that one, and our stats are very high, which is unfortunate. So as the Social Justice Commissioner in 2004-05, I wrote a report to government, and the role of the Social Justice Commissioner is to report to the Parliament, actually, not the government, Parliament, on the enjoyment of human rights by Aboriginal and Torres Strait Islander peoples, and also the impact of government policies. And so I wrote one that looked at health, because there was such a disparity then. It was 17 years, the gap in life expectancy, and for Australia, but there was still 7 or 8 years in New Zealand and Canada and so forth. So I also talked about social determinants in there, and needing to look at that and to take a fresh approach to the way that we looked at health here, and looked at it from a human rights perspective, and use that as the foundation of what we're doing and trying to guide government. It worked. We formed a group called the Close the Gap Committee. These are just members of that committee, and as you can see, it comprises of peak bodies in both the Indigenous and non-Indigenous sector. We formed in March 2006. We still exist. We meet quarterly. We don't receive any government funding, but we're a major advocate for improvements in Indigenous health. So our members contribute a bit of money, which allows us to engage a an executive officer to be able to deliver the service. And I guess the message there is that as Indigenous peoples, as marginalised groups, we can't do it alone. We've got to, buddy up with a whole range of people to be able to progress a cause. And this one is a prime example of it. Excuse me. This is just a photo of our group at Parliament House. And I use this one because from the outset, even though the Close the Gap Steering Committee comprised of Indigenous and non-Indigenous peak bodies and interest groups, from day one it's always been led by Indigenous people. And so whenever we had delegations going to Parliament to meet with ministers and so forth, it was always the Indigenous people that led it. We still do. And we also have a very strong policy of trying wherever possible to have at least 50% female representation in all of our leadership groups. And in fact, they take a very strong leadership responsibility. So this is a Close the Gap campaign. You can, and I'll leave these slides so anybody that wants to have a look at the links and so forth, you can have a look at them a bit later. But these are the sort of resources that we produced as important resources to be able to influence government's thinking. The government did respond, and each year now, the Prime Minister of Australia at the opening of Parliament, in the first session of every parliamentary year, he provides a report back to the people of Australia about what the government's done in the previous year to close the gap in life expectancy and a whole lot of determinant areas. And the opposition also provides their commentary on it, and not always agreeing with the government, of course. And then we, as the Close the Gap Steering Committee, produce our own report, which we call a shadow report, and that's what we from the People's Movement think that government's doing or not doing appropriately. And so these are just some of the reports that we've done, but every year we do it, and it's part of an accountability process, because in human rights terms, people have got to be at the centre, and governments have got to work with people. It's got to be about what we call progressive realisation, that we've got to be able to see advancements, and they've got to be measured, and it's about accountability, and that's where the government, the Prime Minister, reports back to the people of Australia about what they're doing. And it's also about appropriate funding, which is one of our challenges we're still working on. But why health? Because the United Nations Declaration on the Rights of Indigenous Peoples, which has been around since 2007, which we signed off on, has Article 24, which is very clear about health is a right, a basic human right for all peoples of the world. And even though this declaration is about Indigenous human rights, they're no different. There's only one significant difference between the rights that everybody enjoys and the rights of Indigenous peoples, is that rights are generally individual entitlements, whereas for Indigenous peoples we have collective rights. And there's only a few of them, but that's the only significant difference between rights. But looking at both physical and mental health and social well-being is a basic right that's accepted by the UN. Australia, we've responded and developed what we call a National Aboriginal and Torres Strait Islander Health Plan, an implementation plan, and basically again you can see that culture's at the centre, and that there's a whole range of influences on people's enjoyment of good health, and this is universal. These things affect all of us, irrespective of where we go, where we live, and so forth. But you'll see there in that purple ring is about social and cultural determinants. Now this was developed. We co-led this with government. Our committee, we had an equal place at the table, co-chaired all this development. So we've managed to get government to come to the table and work with us. In fact, I'm co-chair or deputy chair of a review team looking at the mid-cycle review of this report as we go along. But In 2017, the government was able to respond through this report, My Life, My Lead, which looked at social and cultural determinants, which is the first time that we've had embedded in public policy in Australia a recognition of social determinants and cultural determinants, which is important. Australia has an emphasis on cultural determinants because they impact on Indigenous peoples, whereas for most of the commentary around the world is mainly on social determinants. But you know, we looked at a number of things, and again, culture was centre of all the deliberations that we have, and governments and all jurisdictions should have on when dealing with working with Indigenous peoples. Racism and this institutional racism was another big challenge that we identified that needed to be addressed, and also the impacts of trauma, because in Australia we've had, as many developed and colonised countries have had, is marginalised people, where governments have forcibly removed people from their land, disassociated them from practicing culture and language and so forth. In Australia we refer to it as the stolen generation. Canada had the boarding schools program, and so we're coming to grips with that. But all the traumas associated with that, and all the other traumas associated with disempowerment and so forth, still are existing, and so they need to be addressed. And time permitting, I'll touch on that in a second, or not in a second, in a few minutes' time. But there's also the need for governments to take a long-term strategic approach to what's happening, and making sure that policy doesn't change with a political cycle. It doesn't change with the change of a minister or a senior bureaucrat, because whilst at the central level, it's easy for politicians and so forth to have bright ideas, but if they're totally disassociated with the reality of what happens on the ground, it's just a total disturbance. And when there's uncertainty about funding, about consistent policy approach, that just destabilises the community. And so, what we're on about is trying to have a stable approach and keeping it together. For those that may not be familiar with social determinants, this is just one of the standards. There's tons of different material about social and cultural determinants, and it's about all those other things other than a clinical response that impact on people's health and social emotional well-being. And health, I always talk about both physical and mental health in these and responses. So it's those other impactors on our health, or that impact on our health, including housing is a big one, employment, education, and so forth in it. So I wanted to now spend a bit of time just talking about one of the programs that I manage, which is about smoking, and I thought I'd start off with a bit of a video to set the scene about tobacco use in Australia, a bit of a historical perspective. It only goes for a couple of minutes, but it's an important one to look at, because it does look at social accountability. How do we mobilise people and to be able to take control of their own health? But it's also very much embedded around an evidence-based approach to action. So, yep.
Tobacco first reached the shores of northern Australia at the beginning of the 18th century. But with the arrival of the first fleet in 1788, British patterns of tobacco use were introduced to Indigenous people.
While white labourers were paid in cash, Aboriginal and Islander people were paid in rations, including sugar, flour, and the worst of all, tobacco.
There is a long experience from the colonial experience that the way to gain power and control over, Indigenous populations is to use these tools.
Tobacco was often given to Indigenous people by Europeans as a token of goodwill, but the British tobacco was highly addictive and soon became popular and widely sought after by Indigenous communities.
This is all part of our traditional country here. And when we used to come down, you know, we catch here, we catch freshwater bream, we catch eel, bungaroos, you know, turtles, all them things. But the mole people, when they did the campfires and everything, that was healing to us. Because you smoke that, you smell that smoke and it goes inside your body, right? And it becomes healing to our body because it flushes everything out. It goes through the system. Where today, we have to imitate that, the cigarette, and that's got poison in it. And that's no good for our body.
Tobacco, flour and sugar was offered by Europeans in exchange for labour and services, and hoped that such bribes would lead the local people to forget their traditional lifestyle. Tobacco became a standard form of currency. During the 1800s, Indigenous people worked in often brutal circumstances for the cattle and pastoral industries, on sugar plantations, on roads, railways, either being paid in full or in part with tobacco.
So if you create a system where people are dependent on a particular commodity, then you then have control over that group of people or that society, because people will require that commodity to continue everyday life.
Okay. So why tobacco? Well, primarily because it's the single biggest contributor to early deaths and chronic disease for Aboriginal and Torres Strait Islander people. It's estimated to be around about 20% as a contributor, and that's just on the health side of it. And when you look at the economic impacts, it's very severe. In Australia, we have a scheme where on the 1st of September each year, tobacco excise and taxes increase, and so part of the government strategy is to actually cost cigarettes to be unattractive to people. And for example, if some of our communities here in the Territory, for one pouch of drum tobacco is about $140. And so when you think that that's a fairly significant impost if you're on a benefit or whatever. So anyhow, I'll just go through some of the stats on tobacco and why it's such a challenge. And this is just the current smokers by cohort. The orange is the general population, and the darker blue is the Indigenous population. So you can see across all age cohorts, we outstrip proportionally the general population, and that's why it's such a significant challenge, and for us to be able to do something about. A lot of our emphasis, we look at the impact on kids and the impacts of passive smoking, second-hand smoke, and in fact we're moving into the realm of third-hand smoke, and you can see again in the statistics that people are very exposed to second-hand smoke, and I guess that's understandable with such a high proportion of the population who smoke. When we look at children who are exposed to smoking in the home or in public areas, it's also very significant, and so part of it, as the video showed, it's and it's one of our challenges. It's become part of the culture. People were provided tobacco by governments, which is really an endorsement of, that it's not unhealthy to smoke, and so it becomes embedded in a culture and as a cultural not as a cultural practice, but it's just in the social culture, and to be able to kick that habit, is one of our big challenges. So second-hand smoking is also really big, and particularly with our young people. If you look back at the other graph at the age cohort, you can see that young people are really taking up smoking as well as being exposed to passive smoke. So a program that I was involved with at the outset with government was the Tackling Indigenous Smoking program, and we kicked off in probably 2010. We started some serious talk about that then, and got a bit of money, and we've been challenged over the years because a lot of the money is for 1 year, 2 years, and so there was a real issue over our employees across the nation who didn't know whether they had a job come the beginning of the new financial year. So they leave, and then you have to do whole recruitment. So a destabilised workforce means an inefficient system. But fortunately, we're into the second year now of an announcement where the government has provided $184 million roughly over 4 years. So we do now have a stable policy. We also have a good amount of money to work. And many people have said to me, well, you've got so much money, and it is, but it's about only $45 million a year, which sounds like a lot, and it is a fair bit. But when you think that every year government's excise and taxes on cigarettes is $3 billion in Australia, so $45 million is a really, nothing money. If we want to look at prevention, and we've got to really start to invest, so it's good. But anyhow, what it is that this money is to rework the workforce that we've got, or we've built in very strongly, targeting pregnant mothers and people living in rural and remote areas where the highest incidence of smoking are, and particularly with pregnant women. You don't get pregnant men, but pregnant mothers. But anyhow, not yet anyhow. They might be working on that one. But it's all those issues that impact on respiratory health and the epigenetics around smoking and the impacts on fetus and newborns. That why it's such a big challenge for us, because we've been able to turn it around in the general population as people got more aware, women got more aware of not only smoking but the passive smoke that's out there, being exposed to smoke in the homes and so forth. So that's a real challenge for us. And leadership is a big challenge, but it's also getting the data, really good data, to be able to show what's happening. So we've taken a population health approach because that's the way to get impact. This is a cloudy little schematic about the program and all the different elements to it, which I won't bore you with, but you'll see I'm there, and I'll touch on a couple of the elements of the program. But embedded in it, in that little squiggly bit on the right hand side, is continuous quality improvement and evaluation and assessment as we go along. So for us, data is so important, and to be able to basically demonstrate impact, but also to make sure that as we learn new things, we're able to refine our program. So we have the quitline enhancement, and I'm not sure if you're familiar with quitlines, but they're run by state jurisdictions here, and they're really a call centre where anybody who is challenged with smoking, wants to understand about giving up, they can dial that number and have a talk to a counsellor, and the counsellor will talk them through, try and identify whether they're addicted to smoking, or whether it's just a habit, social habit, which I think is for many people, particularly young people, it is, and then talk about strategies to be able to address that. And what we've done is we come in with a cultural competency element to it, and we call it quitline enhancement, to ensure that any of the counsellors across Australia, if they get contacted by an Aboriginal person or in fact it's also any minority group, second language person, that they've got the competency to be able to work with them and understand a bit about it. So that's the quitline enhancement. Quit skills is also brief intervention training, which we run out of this program. We contract one of the cancer councils to do it on our behalf, but they'll work with organisations across the nation. We have Circa, which is an evaluation team, and they are looking at our program on the data that we collect, each of the teams. Now there's 37 teams across the nation who run our program, and they have pretty much a national coverage, but Circa does a lot of internal evaluation to assess whether the data that they produce, and they've got to collect data and it goes through the health systems, whether that's having an impact. And we do that because in theory, every time an Aboriginal and Torres Strait Islander person walks into a community-controlled Aboriginal health service, and there's 152 of those around the nation, or to a GP clinic, they should be asked the question, do you smoke, do your family smoke? And that's recorded, and that data is then sent into a central, well, it's not quite central, but they're working on that, repository, so we can tell over time whether people's smoking habits have changed. There's also another evaluation, which is an external evaluation that Ray Lovett and his team are doing from the Australian National University, and that's looking at all the big data, the ABS data, the social survey data, other data that's produced by the Australian Institute of Health and Welfare and so forth, to see, and again, go down to a regional level. We try to refer to postcode level, but it's not quite going to be postcode level, to know whether our program is having an impact. We believe it is, but it's us thinking it doesn't cut it with the government, which is important. And Ray also runs this My Kuwai project, which I'll touch on this slide, which is an important one because it's the first study in Australia that's looking at the impacts of culture on health. And it's one of the few studies in the world, actually, that looks at culture, Indigenous cultures, and their impact on health. And so Ray's surveying about 20,000 people over time and getting data. And there's a strong element in this about smoking, so we'll get some really good data down to postcode level. So he's doing that it's separate to my program, but it's a good one that'll influence it. As a population health program, it's all about partnerships. It's about how we work. My teams work with people in the community, because it's about how do we empower people to understand, empower and educate and empower, so that they take control of their own health outcomes and understand the impacts, but also understand where they can go to for support and what level of support they can get to give up smoking, because it is so significant. It's about capacity building, as I was going to say. One of our big target groups are Aboriginal and Torres Strait Islander organisations that exist around the nation, and there's probably about 5,000 overall, and the majority of them don't have active no smoking policies within their organisations. And some of the Indigenous organisations are housing co-ops and so forth, and one of them in New South Wales has a stock of 500 homes. And so if we can start to look at targeting those homeowners to get them to understand about smoking, and that's going to have a big reach into our population. So in what we do, smoke-free homes, smoke-free workplaces is pretty important in a population health approach, because again, it's about empowerment, but empowerment only happens if you give people education on why they're doing it. So this is just earlier in the year, a photograph of a collective of our teams. That's the majority of them all got together in Alice Springs to go through and get a little pep talk and refocus and all of this into our second year and talk about the emphasis. So I want to just roughly show you what we do. We go out to events. We have our stall. They provide a whole range of information about giving up smoking, but also about diabetes, about the impacts of drinking carbonated soft drinks and so forth on their lifestyle. So we take a lot of information that's got to do with health, even though we're about tobacco, because I think tobacco is one of those taboo subjects. You say you're in anti-smoking and people run away. So if you say you're doing something else, I'll come and have a chat. So we outreach into communities. We've got our teams are very mobile. They work with school kids a lot and trying to change behaviours and to educate kids on why they shouldn't take up smoking, because too much of the approach in Australia has been about smoking cessation, giving up smoking, not enough about not taking it up. And you've got to have both of them if you're going to be successful in the longer term. We talk about the triggers and those associations that people have, out socialising, and that's where you get down to those who particularly are more social smokers than addicted smokers. There's too much of it. We talk about the environmental impacts of cigarette butts, and now we're talking more and more about the little canisters and other holding devices from vaping, and which have a very significant impact, particularly the vials if they contain nicotine, although you're not allowed to, it's illegal to sell nicotine in Australia with your vapes, and but people do buy them off the internet. But we talk about that, and it's really building on the stuff that the WHO has done. So much of what we do is working with others. We have a national best practice unit, and that's a team of people separate to government who go and work with the 37 teams to help them develop their capacity, get them to understand why it's important to collect data and how to utilise the data that they collect for their own continuous improvement. This is an interesting one. Anybody that's interested in following up about strategies to give up smoking or any information about the Tackling Indigenous Smoking program, that's a link on our website. There's a wealth of information on that. We've got a range of other ones. The No Smokes website, that's up there. The My Quit Buddy, which is an app that the government uses, or the government funded, which allows people to take on smoking cessation in their own time. You might be familiar with these apps. They'll contact you every few hours or whatever you want to set it to remind you not to have a cigarette. But they also calculate, and in Australia, a smoker, if you smoke a packet of cigarettes a day in an urban environment, you're spending around about $8,000 to $10,000 a year on cigarettes. If you're in a remoter area where the cost is much higher, then it's up to $12,000, $13,000 or more a year, which is no good. We've got a whole lot of stuff on NRTs, nicotine replacement therapies, and how they can assist in the journey. We have a big campaign called, and it's a public media campaign called Don't Make Smokes Your Story, which is very successful. All the evaluations show that this campaign is the most successful quit smoking campaign, advertisement that's been produced in Australia to date. So we've had a fairly significant investment. It's been over time. So what's been the impact? Well, the key thing is that we are seeing a reduction in those people who were smokers. They're giving up. We've seen an increase in those people who have not smoked and aren't taking it up. So both of them are so important to do. But we're still sitting in the Indigenous population at around about 39%. New data is going to come out in the next month or so, or November, and we're hoping and we're expecting to see a fairly significant increase in that, or decrease in our smoking levels. The non-Indigenous population is sitting at around about 14%. Nationally, they've got a target to get down to 10%, and we're going to try and replicate that target, but we're starting from a lower base, and so we've got a bit more of a challenge to do it. But since the program a little bit more has started, the calculations, this is Ray Lovett's sort of assessment, looking at the quitting rate and so forth, that we have saved 23,000+ lives by people giving up smoking, which is a significant piece of data to remind people that it is important. And we're giving up smoking and not taking it up at about double the rate of what happened in the general population, and that just shows that when you have a culturally appropriate, culturally directed, supported program, that you can get outcomes. And this is, the learnings that we have in tobacco control are really translatable to a whole range of other areas. Diabetes is one of our other big challenges, renal issues here. So, how am I going for time? So I've got 47 minutes, I've still got another few minutes. So I'll go on to another area. Mr. Ray Lovett, Dr. Ray Lovett, who we saw a bit earlier, also did another report which indicated that, and he looked at the general population and the Indigenous population, and looked at it from quitting to the impact on chronic diseases. And what he found was that there's about a 20-year, maybe a little bit more, lag time between when somebody gives up smoking and they're likely to get a cancer. And now for cardiovascular, respiratory, the impacts are fairly quick when you give up smoking. Could be within a year. You're a little bit longer if you do it right. You're not re-exposed, and your lung health is back and your heart health is back. But for cancers, a lag time of about 20 plus years. For the non-Indigenous population, and I won't come back to the non-Indigenous population, that's another slide, they're out of order. But anyhow, so even at the WHO level, we've got World No Tobacco Day. Last year was all about cardiovascular. This year is all about lung cancers and the impact on lung health. So we're on that. And then we get on to another area that I'm on as one of the leaders in cancer control, Indigenous cancer control. And in fact, a little plug, next week in Calgary we've got the World Indigenous Cancer Conference that a good number of us are going over to. But we've managed to work with Cancer Australia to develop up a whole range of resources. Here, the framework on Indigenous cancers, which was a very important document. For the first time, it starts to highlight some of the areas and start to treat Indigenous cancers a bit more seriously than has happened in the past. We've sort of been thrown into the mix of all cancers. We've produced a good toolkit that's widely accepted within the health area on lung cancers and treatments of lung ailments. We've looked at breast cancers and particularly for Aboriginal and Torres Strait Islander women. Our big issue is late presentation and also access to be able to, part of the late presentation because they can't get access, especially in remote areas, even though there are approaches to try and get people out. The breast cancer screening groups are reaching some remote communities, but there's such a time lag between visits. And so even if somebody is diagnosed or they're identified as a concern through one of the screening tests, by the time they get secondary testing and so forth, if it means that they've got to travel to an urban environment, unfortunately, that follow-up is not done. So we've got to do better in that area. But it is being addressed, and we've got some good people. But in relation to Ray's target and the 20-year time lag, what we saw, and this is some important data, this is up until 2012, what we've seen is the mortality rate for non-Indigenous people from cancers is improving, but for Indigenous people it's not. It's going the other way, it's increasing. And so this is part of the data that Ray looked at, because what we call peak tobacco, peak smoking for the non-Indigenous population was around 1992. And so now we're seeing the outcomes of cancers. Mortality is improving because there's less people dying from cancers as we go along, as it's reduced. But for Indigenous people, peak smoking wasn't until around about 2012, 2013. So our 20 or 30 years are still ahead of us. So we're seeing an increase, and that increased even further. And again, you can see the non-Indigenous population, better mortality outcomes than us and the Indigenous population. So that's one of our big challenges now, is how do we, and why it's so urgent to get people to stop smoking. Otherwise, this burden on the health system and on people's lives is going to increase over the coming years. I'll just close with a few other slides. One is on suicides and people taking their own life, which is very significant in Australia. It's increasing for both the Indigenous and non-Indigenous population, even though there's a whole range of measures being put in place. From our side of it, the Indigenous side, we believe that there hasn't been enough put in, and we're working on it. But last year we hosted the second World Indigenous Cancer Conference and the second National Aboriginal Torres Strait Islander Cancer Suicide Prevention Conference, which were very successful in Perth. We've got people from all over the world talking about the issue, learning and sharing, and that's why, events like this where you can sit down and hear presenters, there's a lot of opportunity for learning in those. We looked at the data, and Australia's twice the rate of the general population in other developed countries where there's high Indigenous populations. It's 1 to 1.5 times. So there are opportunities for learning in this environment. I think one of the big highlights, and it's great to see you do it as well, we had a big youth forum, and our youth worked together with us to come up with what they saw as solutions, because I think one of the real challenges for us in the health sector is that we get wiser as we get older, but we also forget that as we get older there's new technologies, new approaches, new thinking following us, and so we've got to look at ways of engaging with our youth and getting them to come up with the solutions or at least try and guide us, and it's our responsibility as older people to grow up our youth and to make sure that we do transfer that knowledge. We do encourage youth to come up and to follow us, because I know in the tobacco control area, where we've got a great cohort of young people coming up. Suicide, we've got a good suicide prevention, a good cohort, and the other thing I need to say too is reminding, we use statistics a lot, and they're very important to encourage, governments to make changes, but each one of those is a person, and it has an impact on us. Now, we should never forget that, that data's great, but the impact on individuals, on families is even greater than what we've got. So I'll close with, just about closing, with a video that's just developed by the youth at our conference. Consider where we go. Thanks.
Thank you very much. I'm Tim from Nigeria.
All right, sorry.
I want to congratulate you on an excellent presentation.
Thank you.
But I have one or two questions. One, you talk so much about the suicide prevention. Good, but have you tried to find out the root cause? Because if you can understand the root cause, then you may be able to eliminate it completely.
Yeah.
The same thing goes for the tobacco issue. Why do they take to tobacco? I think if you find out the root cause, then you may be able to eliminate it. Finally, health, according to WHO, is a state of physical, social, and mental well-being, and not necessarily the absence of disease. And I think some people have added spiritual well-being. Have you looked at the effect of belief system, particularly religious belief, in preventing suicide? Because I've discovered that in societies and communities where there are strong religious belief, the occurrence of suicide is minimal or possibly non-existent, if I'm not wrong. The same thing may go for tobacco. I don't know what you've been able to find along that line. Thank you.
Thank you. I'm sure it varies around the world. We've just had a Royal Commission into child abuse by the churches, and it's currently, the outcomes of that are currently being considered. Unfortunately, we've found that many people self-harm or take their own life have had very poor health outcomes because of their abuse by the church. So I don't think religion, in our case here, has an impact. About 30% of the population follows a Christian religion, only a much smaller percent follows Islam and so forth. So, but then again, in all of those population groups, smoking is still there. There's non-discrimination on religious grounds as to people who self-harm or take their own life. But getting down to the causes, the roots of some of these issues. That's why I had the slide, the little presentation on tobacco. It was something that was introduced, condoned by governments, and it became a cultural practice by people. And we've got to readdress that and to show that smoking isn't part of the culture. One of our big challenges internationally in Canada and the US particularly, where tobacco leaf has a very significant cultural, consideration. One of the big challenges is that when in the old days people presented tobacco leaf as a cultural exchange item, today they're handing out cigarettes, commercially made cigarettes, because it's got a tobacco product. And in fact, next week I'm on a plenary at the World Cancer Conference with a Canadian and an American to explore this very issue about how do we turn it around. I've tried to get it on the agenda at the Permanent Forum for Indigenous Issues, but they've balked at it because of the cultural significance of tobacco into some groups, but I think it's still an issue, and it's nothing to do with culture. It's to do with current modern day practices about commercialised tobacco. Native leaf is very different to everything that's in tobacco today. So I think there's no single answer to whether religion, following any religion or belief, has a better outcome in smoking or suicide prevention. At least we haven't found that here. But what we have found, and the Canadian experience is the same, is that where what we call cultural continuity, where a community is secure in culture and language and is able to express self-determination and self-control, they have less suicides in those communities than those that are being managed and over-managed by governments and other authorities. Culture has a very strong impact.
Thank you, Tom. I'm Ram Marjari from School of Medicine at Western Sydney University. Thank you for your great presentation. Two questions. In Australia, the Indigenous health curriculum usually consists of the history, the epidemiology, and then cultural competency. Is there anything missing, you think, from the current health professional curricula? And number two, as an extension for that, thinking globally, different countries have addressed their Indigenous people's health at different levels, from a large part to practically non-existence. What would be your message for the global health profession education? Thank you.
Yeah, well, I think we'd have to have a better discussion about what's in the curriculum. I think, from my knowledge, only medicine, through the leaders in Indigenous Medical Education Network, the Lyme Network, are the only ones that have got compulsory Indigenous curriculum, or indigenised curriculum in first year. That's mandatory for all doctors in training. In the other disciplines, they're not. There's a whole range of attempts. I've done a bit of work with the nurses to try and get it embedded into curriculum there, and midwives, particularly around smoking and cultural competency, cultural awareness, training. A little bit's been done in psychology in some of the courses. Social work, there's a little bit been done, but it's not across all the all the curricula. I think if anybody wants to see a good practice, and that's the Lyme Network, which is really Australia, New Zealand, some of the Pacific countries are involved in. I think Taiwan may be also involved in it, but that's a model that we need to look at and really ensure that it is in the curriculum. Working with any, we've got to get away from just working with the mainstream and governments, universities. I gave a speech to university just the other week about the challenges, and we're seeing a movement in the university sector in Australia, but we've still got a long way to go. So I don't think there's too many good examples other than Lime Network that we can suggest other people look at. But following on a determinants approach, for me, population health is really an important way to go.
My name is Teresa Marsh. My spiritual name is Makanakwe. I'm Turtle Woman. I'm Indigenous woman from Cape Town, South Africa, and I'm currently residing in Canada. I'm an assistant professor at Northern Ontario School of Medicine. So, Dr. Calma, I was just awestruck and humbly touched and moved by your presentation today, because I think you've highlighted for all of us the importance of that picture there with all our children. It is about reclamation, claiming back that which we have lost as Indigenous peoples across the globe. And of course, the gentleman talking about the root cause, we know that it's about intergenerational trauma. And that people use tobacco and alcohol to numb those feelings and those pains, and that must be highlighted. I think it's very, very important. But you came from a position of empowerment in such a gentle, kind way. It just moved me to tears, because the answer is that our young people, we have to let them know that they're standing on our backs, and you did that. But more important, the video about the love, because any addiction is about that disconnection, and the fact that we need to approach this as healthcare professionals, the spirituality, the reclamation aspect of it, but just also the love, and to make sure that we come from a position of strength. So I thank you deeply from the bottom of my heart, and it gives me a lot of hope, because I only work with Indigenous peoples and see the pain. It's still happening in the here and now. The trauma's not out there. It's still happening to people today. And it is from that position of strength and love. So, Chimikwich, thank you very, very much for today.
Thank you. A couple there.
Good morning. My name is Malaya Santos. Let me just put my stuff down. I'm from the Philippines. I am a member of the Igorot Indigenous peoples. And similarly, I was also very moved and made emotional by your presentation. What struck me most is how clear the data shows the disparity between the Indigenous and non-Indigenous peoples, which I believe, and if anyone in the Philippines, please contradict me, we do not have the data to show that currently. And my question is, what advice would you have, coming from maybe a longer history of affirmative action? How would you advise us to generate the data so that we can also advocate for programs for our Indigenous peoples for health?
Yeah, well, that's, it's getting the systems to be able to have a will to want to collect that data, and sometimes they balk at it because they don't want to hear the answer to some of the data. I think it's taken us quite a while to be able to collect, and it's still not perfect here. I can tell you, we've got major challenges because, as I said at the outset, we've got state and territory jurisdictions, and their systems don't all talk to each other. And so somebody's got to manually assess them if it's not done through what we call a social survey or the census data that's collected. But even in the census data, the government's been very reluctant to include a whole range of questions on smoking. And for us, it's a big issue. It's a lesser issue for the general population, but when you're still sitting at close to 40% of the population, and some of our remote communities, up to 80% of people smoke, and it's horrible, and it's the urban environment and their reduction in smoking that makes the figures look good, but across the nation we've got some really big pockets of high incidence smoking. So I think it's a matter of just continually trying to get the governments or the systems to be able to collect that data, but it's not an easy one. It's taken us forever to do it, and we're still refining it. But the universities, I'll be pushing the universities to do a bit more research in this area. And of course you've got Vicky Talley-Corpus, who's the Special Rapporteur on Indigenous peoples at the United Nations. He's a good Filipino.
Tom Dimity Pond. I'm Professor of General Practice at the University of Newcastle.
Hi.
And we're proud to have graduated a number of Indigenous doctors. I'd like to thank you very much for that very inspiring talk. I'm the Western Pacific Regional Rep on the board of TUFH, and we're proposing a series of webinars, symposia and discussions online over the next 12 months to share some of the experience from each region with the other regions and within the regions, so that we can learn and from each other. And I think some of what you've said is so inspiring and so interesting that we'd really like to incorporate some of that into some of those activities if possible.
No problems. I see you've got a camera here, so you can just broadcast it all.
Thank you very much,
Thank you.
Tom. Okay.
Thank you for your comments.
Thank you, Professor Calma, for giving us a lucid picture of the diversity of the Indigenous population in Australia and literally walking us through the entire scenario, starting from the history to the future and how we tackle the challenges. So as someone from India, which is actually home to a large group of Indigenous population, though our government does not officially consider them as Indigenous, operationally we do have some communities, in fact a large section of communities which actually belong to the category of Indigenous. Also as a young healthcare professional, when I have been sensitized regarding the challenges which they face in the field of healthcare during my clinical rotation in a remote area. So listening to these stories and a similar scenario in the Australian context, the similarities, figuring out the similarities and the disparities, and also how we can actually move forward, and thus, in fact, the lifelong dedication, the story of your lifelong dedication for the upliftment and empowerment of the communities was in fact a thought-provoking and more importantly, an inspirational experience for all of us. So on behalf of the Network Towards Unity for Health Family, I would like to extend our gratitude and appreciation to you for accepting our invitation, for sharing your valuable time with us, and for giving us a comprehensive idea of how we can set our goals and how we can actually move forward as a community in bridging the gap in the field of First Nations health. So, and we would like to present a small token of appreciation for the same.
Thank you. You'll get a photo after. Yeah. Thank you, folks. Appreciate that.
So thanks to all of you for your patient listening. It's time for the coffee break, and I request all of you to move to the exhibition hall for the same.